Welcome to part 2 of GU. We're going to be discussing uncomplicated urinary tract infections. Urinary tract infections, or UTIs, are unfortunately very common in adults and older adults, and in females more so than males. They're very common healthcare associated infections as well. Urinary tract infections are infections that occur anywhere along the urinary tract, and we classify them as upper or lower tract infections. Upper tract infections occur in the kidneys, and we call this pyelonephritis. Lower tract infections could include the bladder, which we call cystitis, in the prostate in males, and we call this prostatitis, or can be urethral, and we call this urethritis. UTIs can be acute or chronic, and unfortunately, they can be deadly if not treated quickly and correctly. UTIs can cause sepsis, specifically urosepsis, which does cause death, acute kidney injury, which means it causes severe short-term kidney damage, and UTIs can also cause enough short-term kidney damage that it can become chronic kidney damage. In Block 1, we do not discuss sepsis or kidney damage, so we're going to focus on UTIs that do not cause any of these problems, and we call those uncomplicated UTIs. There are several risk factors for UTIs. The first is being female due to that short urethra, making it easier for bacteria to enter the urethra and making its way up to the bladder. Men do not have a short urethra, so it's not as common that they get a UTI. Anyone who is sexually active is at a higher risk of getting UTI, but females more so. Menopause in women causes abdominal muscle walls to get weaker, which makes the urethra sag and more prone to UTIs, along with the loss of normal flora in the pelvic region, keeping the bad or uropathogenic bacteria in check. Foley catheters are inserted into the urethra to the bladder, allowing for a pathway for bacteria to enter the bladder. There'll be another PowerPoint on that specifically later. In diabetics, which we'll learn about later in Block 1, diabetes causes all diabetics to be at higher risk of all infections, and then also changes to ADLs and urination in older adults, especially older men, puts older people at risk for more UTIs. There's one more risk factor to UTIs that's not commonly discussed because there's no way for us to know it's occurring unless the provider does more in-depth imaging studies, and that's called reflux. Urine can reflux, meaning it goes back to where it came from, which causes old urine to go into places where it should only have brand new clean urine. Picture A shows how urine would normally flow from the bladder to the urethra and out of the body. Picture B shows how sometimes urine can reflux up the urethra and go back into the bladder. This means any bacteria that could have been sitting in that old urine in that urethra has now backed up into the bladder. It should not be there, and this is now a risk factor for UTI. Picture C shows how having a full bladder, it can't hold any more urine. And that urine has got to go somewhere, and it backs up into the ureters where it's going to make its way back into the kidneys. Picture D is showing incomplete voiding, meaning the bladder didn't fully empty when the person urinated, so now there's old urine sitting in the bladder, and that could reflux back into a ureter, which is not a good sign. Unfortunately, half of the people with the UTI don't know they have it. They have no symptoms, and we call that asymptomatic. For the half that do know that they have UTI, they're usually going to complain about painful, burning urination called dysuria. It hurts. They don't even want to urinate because urinating hurts so badly. They may also complain of pelvic and abdominal pain, and they'll also get increased frequency of urination because it hurts so badly that they don't want to empty their bladder completely. And then some of the common UTI bacteria actually irritate the lining of the bladder, so the detrusor muscle thinks that it has to urinate every few minutes. People will also feel the urge to urinate all night long, and that's called nocturia. Some people may lose the ability to urinate on command, which is incontinence, and some may see blood in their urine. The urine may have a foul odor, and it may turn cloudy from all of the bacteria. Older adults are usually the ones who don't have any symptoms of a UTI until it's too late and they become uroseptic. Confusion, lethargy, fever, and hypotension may be the only symptoms they have that they're sick, and by that time they're very sick and they'll be hospitalized and they could possibly die. The best and easiest way to assess for UTI is a urinalysis with a culture if bacteria are present. When we look at a urinalysis to see if a person has a UTI, we will see that the color of the urine is normally its normal yellow color. The UTI shouldn't change the color too much. The clarity can be clear if it's early in the UTI, but the urine is usually going to start to turn cloudy or hazy as the bacteria multiply. The pH may be normal, but it can be high, meaning anything above 8 with a UTI. The specific gravity and osmolality should stay normal. There should not be any glucose, protein, or ketones present. There should be WBCs or white blood cells present, and some labs may result a lab value called leukocyte esterase, which is an enzyme found in white blood cells. If leukoesterase is present, it means that there is some sort of infection or inflammation in the GU tract, and that's normally indicative of a UTI. There may possibly be red cells present if the kidney has damaged from the bacteria, or if the bacteria has irritated the lining of the bladder enough to make it bleed. There should be many bacteria present, and there may or may not be nitrates present. Nitrates are a waste product produced by only certain types of bacteria, so depending on what bacteria is causing the UTI, not all UTIs will have nitrates present. When we determine our problem and our goals for our uncomplicated UTI patient, we really need to look at what the patient's main complaints are. Many uncomplicated UTI patients have the biggest complaint of pain, so often pain is our priority problem. The opposite of pain is no pain, so our outcome and goals would be to relieve that pain. Other goals we should have are to increase their knowledge about how to prevent and treat UTIs so they don't have recurrence or have complications. If our UTI patient is having issues with urinating normally, we may need to teach and reinforce strategies to promote normal urination. When we treat UTIs, the provider can order a couple of medications. The first would be an antibiotic that is specific for UTIs. There are 3 main oral antibiotics for UTIs: nitrofurantoin or macrobid, fosfomycin or Monurel, and sulfamethoxazole trimethoprim or Bactrim. The provider usually starts with one of these and sees how the patient responds. If the sensitivity comes back showing any of these don't work, or one works better than another to kill the bacteria, the provider may change the antibiotic to make sure all of the bacteria gets killed off. The provider may also prescribe an analgesic specifically for the bladder called pyridium. This turns the urine orange and numbs the bladder and urethra so it doesn't hurt to urinate. This is for pain management only, and it does not kill any bacteria. This fact is huge for educational needs for our patients. They'll think that they don't need to take the antibiotics because the pyridium is making the pain stop, but not taking the antibiotics will cause complications quickly. Some people like a heating pad on their abdomen to help relieve pain, and that's okay with the provider's order. We want to have the person increase their fluid intake to help flush the bacteria out of the bladder to help symptoms and to get rid of the bacteria faster while the antibiotic is killing them. We want to help them stay away from fluids that will irritate the GI tract, like coffee, tea, cola, and alcohol. If our patient needs help using the toilet, we want to get them up frequently and at regular intervals to help them urinate. We also want to educate and encourage them to fully empty their bladder when they urinate. We also want to maintain skin integrity because urine on the skin can cause skin breakdown, just like stool can, and we don't want to have that happen. Patient education is very important as well. Not only do we need to teach them to take all of their antibiotics as ordered, we need to teach them to not stop taking them if they feel better and to not save the antibiotics for later. An entire course of antibiotics must be taken for the UTI to resolve. We also need to teach our patients proper hygiene. For females, they need to wipe from front to back always. Sadly, the most common bacteria for UTIs is E. coli, which is a fecal bacteria. Everyone should be taught to urinate after sexual activity. And we also need to educate people to urinate when they feel the urge and not to hold their bladder until they can't hold it anymore. When they hold their bladder, that increases the risk of urine reflux. When we evaluate our patient's goals and outcomes, we're really looking at symptoms and infection. Is the patient voiding without pain, burning, and frequency? Is the patient following the education we taught them, like taking all of their antibiotics and wiping front to back? Are they increasing their fluid intake and voiding when they feel the urge? Honestly, when it comes to UTIs, preventing the UTI in the first place is the best treatment. If a person who gets a UTI doesn't change their hygiene and urination habits, they'll continue to have UTIs. And if they don't take all of their antibiotics as prescribed, there are major risk of having a complication or repeat UTIs that are just going to get harder and harder to treat as the bacteria become immune to the antibiotics we have. Antibiotic misuse is extremely common in America, and it's caused by many bacteria becoming resistant to the antibiotics we have. We will eventually run out of antibiotics to treat common bacteria, and when this happens, the human race is doomed. And this is the end of part 2 on UTIs.